Hypertriglyceridemia. Introduction. Hypertriglyceridemia is one of the most common lipid disorders encountered in clinical practice. It refers to an abnormal elevation of triglycerides, a type of fat, in the bloodstream. Triglycerides are the body's major form of stored energy, primarily derived from dietary fats and carbohydrates. While they are essential for metabolism and energy storage, excess triglycerides are harmful and can lead to significant clinical consequences. The condition is often asymptomatic in its early stages, but it is strongly associated with atherosclerotic cardiovascular disease, ASCVD, and acute pancreatitis, especially when triglyceride levels are very high. Due to increasing prevalence of obesity, sedentary lifestyle, and diabetes, hypertriglyceridemia has become a significant public health issue globally. Definition. Hypertriglyceridemia is defined as fasting serum triglyceride levels exceeding 150 milligrams per deciliter, 1.7 millimoles per deciliter. Classification, according to NCEP ATP3, normal, 150 milligrams per deciliter, borderline high, 150 to 99 milligrams, high, 200 to 499 milligram, very high, times 500 milligrams per deciliter, risk of pancreatitis significantly increases above 1,000 milligrams per deciliter. 3. Etymology. The term is derived from Greek and biochemical roots. Hyper, Greek over or excess. 3. Glyceride, a compound of glycerol with 3 fat acids. Emia, from Greek hema, meaning blood. Thus, hypertriglyceridemia literally means excess triglycerides in the blood. 4. Epidemiology. Globally, 25 to 30% of adults have triglyceride levels above normal. Prevalence is rising due to urbanization, sedentary lifestyle, and Western diets. Gender differences, more common in men, but risk rises in postmenopausal women. Ethnic variations, higher prevalence in South Asians, Hispanics, and Native Americans. Comorbidities, up to 80% of patients with type 2 diabetes have hypertriglyceridemia. 30 to 40% of obese individuals are affected. It is a major component of metabolic syndrome, along with central obesity, hypertension, and insulin resistance. Chapter 5. Types A, primary genetic, caused by inherited lipid metabolism abnormalities. Examples include 1. Familial hypertriglyceridemia, overproduction of VLDL. 2. Familial combined hyperlipidemia. 3. Familial dysbeta-lipoproteinemia, type 3 hyperlipoproteinemia, ApoE defect. 4. Lipoprotein lipase deficiency, rare. B. Secondary, acquired, due to lifestyle or comorbid conditions, diabetes mellitus, obesity, alcohol abuse, hypothyroidism, chronic kidney disease, medications, corticosteroids, estrogens, protease inhibitors, beta blockers. 6. Causes, genetic, defects in ApoC2, ApoE, or lipoprotein lipase, dietary, excess refined carbohydrates, sugars, saturated fats, alcohol, endocrine metabolic, diabetes, insulin resistance, hypothyroidism, Cushing's syndrome, systemic diseases, nephrotic syndrome, chronic kidney disease, liver disease, medications, oral contraceptives, corticosteroids, diuretics, antiretrovirals, tamoxifen. Risk factors, family history of hyperlipidemia or premature cardiovascular disease, male gender, increasing age, and postmenopausal status in women, obesity, metabolic syndrome, sedentary lifestyle, diabetes mellitus and insulin resistance, excess alcohol intake, smoking, chronic kidney or liver disease. 8. Complications 1. Acute pancreatitis. Severe risk if triglycerides 1,000 milligrams per deciliter due to toxic free fatty acid release and pancreatic inflammation. 2. Cardiovascular disease. Accelerates atherosclerosis, myocardial infarction, stroke, peripheral vascular disease. 3. Hepatic complications. Non-alcoholic fatty liver disease, which may progress to cirrhosis. 4. Metabolic syndrome. Increases risk of diabetes, obesity-related complications, and hypertension. 9. Pathophysiology. Triglycerides are transported in blood via chylomicrons from intestine and VLDL from liver. In hypertriglyceridemia, overproduction of VLDL in liver. Impaired clearance of triglyceride-rich lipoproteins due to lipoprotein lipase dysfunction or insulin resistance. Excess TG-rich lipoproteins deposit cholesterol in arterial walls, atherosclerosis. Extremely high triglycerides, 1,000 milligrams per deciliter, chylomicrons obstruct pancreatic capillaries, inflammation and necrosis, acute pancreatitis. Signs and symptoms, usually asymptomatic until very high levels. Dermatologic, eruptive xanthomas, yellow papules on back, buttocks, extensor surfaces, palmar xanthomas, type 3 dysbeta-lipoproteinemia. Ocular, lipemia retinalis, creamy white retinal vessels when TG 2000 milligrams per dl. Abdominal, recurrent abdominal pain due to pancreatitis. General, fatigue, hepatosplenomegaly in severe cases. Medical diagnosis, fasting lipid profile gold standard. Triglycerides, total cholesterol, LDL, HDL. Blood glucose and HbA1c to rule out diabetes. Thyroid function tests to rule out hypothyroidism. Liver and kidney function tests to check for secondary causes. Imaging, ultrasound CT for pancreatitis fatty liver. Genetic testing in suspected familial cases. 12. Nursing diagnosis, imbalanced nutrition, more than body requirements related to excess calorie intake, risk for decreased cardiac output related to atherosclerosis, risk for unstable blood glucose level related to insulin resistance, knowledge deficit regarding disease, diet, and management, anxiety related to risk of complications, CVD, pancreatitis. And 13. Medical management lifestyle, low-fat, low-carbohydrate diet, avoid alcohol and simple sugars, regular exercise, 150 minutes week, weight reduction, pharmacological therapy, fibrates, first line for high TG, omega-3 fatty acids, fish oil, EPA DHA, statins if LDL-C also high or ASCVD risk, niacin less used now, insulin therapy in acute severe cases with pancreatitis, acute severe cases, hospitalization, IV fluids, insulin infusion, plasmapheresis, rare. Number 14, nursing management. Monitor vital signs, lipid profile, and glucose regularly. Educate on dietary modification, low-fat, low-sugar, high-fiber diet. Encourage exercise and weight control. Monitor for signs of pancreatitis, sudden abdominal pain, nausea, vomiting. Ensure adherence to medication. Provide psychological support and lifestyle counseling. 15. Treatment options, non-pharmacological. Diet rich in vegetables, whole grains, omega-3 fatty acids. Weight loss, exercise, alcohol abstinence, pharmacological, fibrates, statins, omega-3 fatty acids, niacin. Advanced options, plasmapheresis in severe cases, insulin infusion in diabetic hypertriglyceridemia with pancreatitis. 16. Psychosocial interventions. 1. Counseling for diet modification and physical activity. 2. Stress reduction, yoga, meditation, relaxation techniques. 3. Support groups for patients with diabetes, obesity, or lipid disorders. 4. Family education to encourage healthy lifestyle habits. 5. Cognitive behavioral therapy, CBT, for adherence to long-term treatment. Hem 17. Prevention. Regular lipid profile screening in adults every 5 years, earlier if risk factors present. Maintain ideal body weight, BMI 25 kilograms per diet. Healthy balanced diet, avoid refined carbs, saturated fats, and alcohol. Daily physical activity, minimum 30 min. Smoking cessation. Control of diabetes, hypertension, and other comorbidities. Conclusion. Hypertriglyceridemia is a common but often silent lipid disorder with potentially life-threatening complications such as pancreatitis and cardiovascular disease. Its management requires a multidisciplinary approach involving lifestyle changes, pharmacological treatment, nursing care, and psychosocial support. Early detection and preventive measures significantly reduce long-term morbidity and mortality. A combination of patient education, lifestyle modification, and regular monitoring is essential to control triglyceride levels and improve overall cardiovascular health. Thank you. Have a nice day.